Ethical Perspectives on the News is produced by the Interreligious Council of Linn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV 9.
Good morning, and welcome to Ethical Perspectives in the News. My name is Pete Welch, and I'm the moderator for this morning's show. This morning, we'd like to talk about a topic of concern to the Cedar Rapids area regarding the local hospitals we have and whether competition is in the best interest of the general public. First with us this morning is Dr. Marianne Miller-Meeks, who's Iowa's Director of the Public Health Department. Good morning, Mariette.
Good morning, Pete.
Second with us is Dr. Ghosh, who's with the Ghosh Cancer Center here in Cedar Rapids.
Good morning.
Good morning, Doctor. And last but not least, we have Bob Rush, who's an attorney here in Cedar Rapids with Rush and Nicholson and was a former Iowa legislator in Des Moines. Good morning, Bob.
Good morning.
Thank you all. The people in Cedar Rapids have seen a market competition between our two major hospitals of Mercy and St. Luke's. What are the pluses and minuses of having two hospitals that are doing the same mission or the same type of business in an area such as this? Doctor, you, as the Director of Iowa Public Health, is it good to have that kind of competition in the community?
Well, it depends on if you have a true marketplace where competition helps to reduce price. In the case of healthcare, where you have a price, especially in Medicare and Medicaid, where the price is fixed, then there may be little advantage to competition or little competition because you're trying to lure the same patient, if you will, but the price is the same because the price is fixed and determined by those payers, i.e. Medicare and Medicaid. But in other instances, such as LASIK eye surgery, which I've done, competition can be very good at driving down price but still having and maintaining quality.
Okay. Doctor, you have worked in both hospitals from time to time?
No, I still work for the both hospital. I'm active staff, and I can tell you, I travel quite a bit. These two hospitals provides an excellent care. These two hospitals always has been in competition to capture more market share. But I have seen over 23 years in this town that there are some patient who is going to go to Mercy Hospital, no matter what you do, and there are some patient who is going to go to St. Luke's Hospital. So I don't think that in this town the market could be changed a whole lot. Plus what you said is absolutely right. I mean, there is really no competition because the price is fixed by the insurance companies. So I think we are spending a whole lot of money trying to have more business. Mercy is trying to have more business. St. Luke's is trying to do all the business. In my opinion, I think we are increasing the cost from both hospitals. Their cost is increasing. I don't think they're going to see a shift in the market share.
Okay, but with the competitive market being between the two hospitals, are they maybe a little bit more advanced in getting newer procedures here than if one hospital was here alone and didn't have to worry about modernizing equipment?
Well, I think this is a simple question, but the answer is very complex. We need to see what is happening across the country. Across the country, the business of medicine is taking a priority, and hospitals are trying to have more say in the healthcare. When I came to this town, the physician was very strong. They had their own voice. But now that voice is going away as it has gone outside Iowa. You know, Iowa tends to follow by 4 or 5 years. So now what is happening is both hospitals is trying to have their own staff and try to do more in their own. And really many times there is a duplication of care. And I don't think that improves the care of the community.
Okay. Mariette, as somebody who's now looking at the bigger picture across the state, is Cedar Rapids typical of the Iowa communities, and in getting its care, and are we those 4 or 5 years behind the coasts, if you will?
Well, I think you have to put things in the context of the Affordable Care Act or healthcare reform. So when you're talking about competition or certificate of need, meaning can you limit what services somebody offers in order to keep prices stable or prices at a set level, you can't take that just by itself. So in the context of healthcare reform, with a drive and a push towards an accountable care organization, what you're seeing across the country, and I think this is what Dr. Ghosh is referring to, you're seeing a lot of consolidation. Now in Iowa, we haven't seen hospitals purchasing hospitals and consolidating in that manner, although that is happening across the country to a very high degree. But what we have seen in Iowa is hospitals, and again, I think this is what Dr. Ghosh is referring to, hospitals purchasing provider practices. Now, it's not uncommon for hospitals to have had primary care practices, but they're also now purchasing specialty care practices or provider practices. When you have that degree of consolidation, then you have to ask yourself, can you control prices in that scenario because there's not competition to try to help drive prices down, even where you can, and that's in the commercial payer market. So what you're seeing, so for instance, a procedure done in an ambulatory care center almost always is less than the same procedure done in a hospital. But if hospitals are purchasing ambulatory surgery centers, then you don't have that ambulatory surgery center which acts as a check on the hospital price. And then the ambulatory surgery center is purchased, it becomes part of the hospital is reimbursed at a higher rate, and so what happens is the cost is actually going up instead of the cost going down.
Bob, now, she used a term called certificate of need. Now, I understand, did you have a role in developing this in Iowa?
In the Senate, right. I authored the Iowa Certificate of Need bill that became the law.
Now, for the purpose of our audience,
behind
can you give us the background?
It was actually a President Nixon initiative that nationwide states were encouraged by money to come up with health policy planning. And part of that planning process, they developed a certificate of need process. And that was set up to ensure or to try to protect against duplication of equipment, unnecessary building. The obligation was on the provider that wanted to provide that service or get that expensive piece of equipment to demonstrate a need. And you have to go through, and you still have to go through, a process that requires approval of that. Although the law, I must say, has been watered down considerably from what it was in the beginning. I think a number of hospitals have been exempted out. The dollar requirements now, I think it's $1.5 million is the threshold, is it not, in order to even begin to seek approval. You don't need it if you go up to 1.499. So it's a process that is changing, as the doctors have indicated. We're going to see dramatic change, I think, with the Affordable Care Act, because it may be replacing this regulatory framework with a more built-in competitive model. And for those that think the marketplace is a good place to make healthcare decisions, they have that in the Affordable Care Act.
Now, part of what you're talking about is if you want to introduce to a marketplace a special procedure, then you must go out and justify what you want to do to a particular board?
Correct. And the example would be in the late 70s, an MRI machine was the hottest piece of new equipment, and everybody wanted one, but the hospital that maybe already had one was only using it 20% of the time. So the idea behind the law was, hey, we don't need another one, because who pays for it? The insureds, the patients, all of us pay for it. So that was the reason. So
less procedure and more facility, although it is different in different states. So in some states, their certificate of need would be for ambulance services, radiological services, dialysis. It could be procedural, but typically it's facility or equipment based. And Mr. Rush is correct. In Iowa, our limit is lower than it is in other states. You can go significantly higher, but you also can completely renovate a facility, a hospital facility, or a nursing home facility if you don't increase the number of hospital beds or you don't increase the number of surgery suites. So that can have an effect on how much you can do and the price tag that you can spend. But the question is now, is it, and I would agree with Mr. Rush also that it's been the law has been watered down. But it's very interesting that when we were contacted about doing the show, I had just read something earlier this year in Modern Healthcare about coronary artery bypass surgery. And the study was done with the National Institutes of Healthcare Research and National Institutes of Health, looking at coronary artery bypass graft, which is heart surgery done to replace blocked arteries. And so if you look at the procedure done in states with certificate of need, states without certificate of need, they found that the cost was lower in those states without certificate of need. And so that was kind of interesting to me because it's sort of different than what I had read about, at least in Iowa. Now, when it came to stents, they found that it was negligible. There was very little cost difference when it came to stents. And there was just a suit that was going through the 4th District Court in Virginia that was brought by healthcare providers, by physician groups, and they found that it was anti-competitive and held for the provider group over the hospitals. So it's interesting. I think there is some revisiting, especially in the context of healthcare reform and an accountable care organization. So if you have an accountable care organization and it's paid per, not per volume, but per value. So it's paid, the system gets a set amount of money to take care of a population. That changes this whole dynamic of should you have certificate of need and what competition is like. And as I said, not necessarily in Iowa, but in other states, it has driven consolidation and mergers between hospitals.
But we are seeing, a growing alliance of hospitals. And that's being driven in part, that's market driven, also driven, I think, by Affordable Care Act, which is encouraging those sort of alignments, I think, for competitive reasons.
Well, we've seen here in Cedar Rapids, we've seen Luke's and Mercy both going to the smaller communities and buying or aligning those practices. And then just recently in the marketplace, now you've seen that Mercy's gone up and is showing up with the University of Iowa hospitals and clinics in a marriage there. Can we expect that Luke's is going to have to do something like that?
Luke's is already very much part of Unity, and that's, I believe, the biggest hospital group in the state.
So I think, we need to look into this issue. As I said, it's a complex issue. One is that if I am the CEO of a hospital, hospital's revenue is when the people get sick. The hospital revenue is not in prevention of care. So if I am the CEO, I want to make sure my institution is healthy. So to do that, I want to make sure more patient comes to me. And the one way you do that is have more specialists and primary physician employed by you so that they come more to the hospitals. And Surgicare and others should be owned by the physicians, but now it is owned by the hospital too. So if I am a businessman, I think what is happening in Cedar Rapids makes sense. And the accountable care organization is making those things happen faster because accountable care organization says that group come together, hospital and physicians come together and be accountable for some care and you save your cost. So the rules and regulation is pushing to that direction than ever. And the other is like if you are out of medical school, it is almost impossible to start a practice because of the rules and regulation. It's a nightmare. So when somebody is coming out of the medical school, they need a job. Many times they have no choice than to join a strong organization, which is hospital-based organization. They have more revenue, they can share the revenue and sustain in the business-wise. So business-wise, it makes sense. What you are asking is that as a community, does it make sense when we are duplicating the care and also try to put so many advertisement in the TV and other, is that healthcare is improving? And the things that we are not answering here is, what is the quality indicator? I mean, yes, we are doing the bypass, but how many of them need the bypass? And now all the physician organization is saying that, everybody is saying that we as a physician has a responsibility to cut down the cost. So whole issue is very hard to really answer, whether this is right or wrong. It's just a very complex process.
If I could, I'm just going to clarify one of the things Dr. Ghosh said, and that is, when we're talking about duplication, I don't think he means duplication in the sense that an individual gets a CAT scan at each organization or each hospital or an MRI. So when he's talking about duplication, he means that each of the entities offer similar services.
Yes.
So I just wanted to kind of clarify that. And again, with an accountable care organization and consolidation, then that begs the question, is there competition, and competition that helps to reduce prices in the commercial payer market where the fee is not set? And I think what we're going to see is that there is, in fact, less competition and that prices will go up. Again, I'll take the example of an independent ambulatory surgery center or an independent oncology center or an independent plastic surgery center, and that if you go and have a procedure there or you're having your care there, it could be less than at a hospital. But if the hospital is purchasing those provider practices as part of the accountable care organization, then you don't have that competition that held prices down. And even at a fixed price, the reimbursement to an ambulatory surgery center is less than the reimbursement to a hospital.
The old model, I think, Peter, as far as hospitals go, really was not competition based on price. It wasn't competition based on outcomes. In this community, certainly quality hospitals, price is virtually the same. And so we're spending tens of thousands, hundreds of thousands of dollars of advertising, not competing on outcomes or quality or cost, but selling fancier rooms or things that are inconsequential in the long run. The new model, and none of us know what it's going to produce, builds in incentives to keep people healthier in the long run, and will pay you more if you do that. We'll see.
I know that we've seen a lot of advertising in Cedar Rapids with each of these two hospitals saying that they're on the top 100 hospital lists in the country, and I scratch my head and think, gee, we've got 2 out of the top 100 hospitals in the country in Cedar Rapids. It just didn't seem to make a lot of sense. I know they're both good, but I just didn't think they were that good. So it kind of depends on the measurements and the parameters and which hospital study you're paying to subscribe to, isn't it, Marriott?
It is, and it also depends on what it is that you determine to be quality. So for some people, quality, and as the quality indicators the hospitals have currently, are whether or not you got your flu shot, your mammogram, your pneumonia shot, did you get your colorectal cancer screening. For me, quality is, if I get in a motor vehicle accident, or if I have a heart attack, or if I get breast cancer, heaven forbid, I want to know that you have the best survival rate in the world. And right now, the United States is where that is. So I would say probably the 2 hospitals are highly rated and up at the top. But yes, there is peer review when it comes to rankings and other things that go into the rankings of hospitals. So there are a list of quality metrics.
And you can probably go to any marketing company and find yourself on somebody else's favorite list. It's a marketing device.
Down in the road, the consumers or the patient will demand data like, for example, you have breast cancer, and say, for example, I hope you never get it, but so you are going to get chemotherapy. Now, everybody gives chemotherapy. Who does a good job? Now, those data is beginning to come, and we don't have those data. For example, any institutions where what they are supposed to give and what they have given, the ratio is called relative dose intensity. If it is less than 85%, you might be wasting your time and energy because there is a tremendous failure rate. So those are the data that people will need to see, that what is your relative dose intensity, and during those care, how many of them has been hospitalized, how many visited the emergency room, because those are the actual quality. Because I think whether they get a flu vaccine or not will not be a quality measure down in the road, because it is expected that if you are going to practice medicine, you are going to do that with your patients. Like there are data and those data comes from European country, like when you give tamoxifen, a medicine that is highly effective in reducing the death and relapse. There is no other drug that makes such a difference and such inexpensive drug. But the compliance rate is poor. And when you have a compliance rate less than 80%, there is a failure and there is an economical data. So I think what we need to figure out, what is your compliance rate? If you are an oncologist, or if you are University of Iowa or Mercy Medical Center or St. Luke's or my office, what is my compliance rate? That's the data that we need to know, and that's the way we should rank the hospital, whether they are good or bad.
Well, I think that's coming, though.
It's coming.
I mean, part of what happens with, with accountable care organizations is precisely that type of outcome. So to provide that data, what's your compliance rate? How do you figure out how to help your patient to be compliant? Because you're responsible
Yes.
for the outcome regardless.
Yes.
So the care is no longer the care once they come to your door, whether it's at a physician's office or a hospital or an emergency room. The outcome is, if that's your patient and they're allocated to you, then you're responsible for the outcome.
Yes.
Do you think we're going to actually see an apples versus apples way of grading all of these different hospitals, or are you going to get organizations that say, I'm better on that scale than any other, therefore I want that scale?
Well, here's an example of comparing apples with apples. When the Certificate of Need law was enacted, the legislative battle had to do with the hospitals, big and small hospitals all across the state, fighting on something called uniform accounting versus uniform reporting. And the hospitals were just dead set against uniform accounting because that would have made it easier to compare procedure with procedure, cost versus cost. So we ended up with uniform reporting, not uniform accounting.
But I think, yes, we're moving in that direction. It will be easier for comparison, apple-to-apple comparison. There'll be qualifiers and modifiers, but I do think that you see the trend is certainly going in that direction, and that's both within provider offices and in facilities as well.
Absolutely. I think we are moving to a better direction, and we'll have a better quality indicator. And the process already has been started.
And Mariette, I know that Iowa has lagged behind on its Medicare reimbursement amounts compared to other parts of the country. Will this hopefully bring Iowa forward and maybe a little bit more on a level playing field, or is that just a pipe dream?
Well, sir, now see, you're asking a political question rather than a
Okay.
healthcare question. And the reason I say political is that the reimbursement, remember that you have a certain amount of funding that goes to Medicare. And right now, healthcare is a tremendous part of both the state budget and the federal budget. And so in order to give more to Iowa, despite having excellent quality, that means that you have to give less to some other state. And we're not a big state. We need more people to move to Iowa so we can increase our population, because certainly what people pay in their Medicare tax, okay, is the same in Iowa. So you're paying in the same, your premiums are the same, your deductible is the same. So if we have high quality, And a lot of the reason we have high quality is that we have providers that communicate with their patients, patients that interact with their providers and, do comply with their regimens. And so we do have high quality. But it's going to be difficult because you have to shift from entities that are getting paid more for a certain procedure than less. The last time I talked to Senator Grassley and Senator Harkin and our representatives about this, I said if the federal government really wanted to save money, and I do cataract surgery or did, since you only reimburse us $580 or $560 for cataract surgery, you ought to be sending everybody in the country to Iowa for surgery because we've got excellent visual outcomes, but you pay us less. But it doesn't exactly work that way.
And you mentioned the word political. I better chime in here, Peter, that there's one party, as you know, that is challenging what's called entitlements, and that's primarily Medicare and Social Security. But Medicare, if it's a target, it's to reduce expenditures, not to give our underpaid doctors what they should be paid, because we're like 49th or something.
I'll say underpaid providers and hospitals, so it's the entire gamut along that stream.
Yeah, although I must say, I don't know about hospitals, because when I see our nonprofit hospitals and the number of administrators that have increased compared to the much smaller increase in provider doctors, and then I see what we are paying CEOs of nonprofit hospital organizations, it gives one pause.
Certainly does, and we still have the sort of Damocles hanging over our head because there's the 24% cut to Medicare reimbursement that's still on the table for Congress in this January. And typically what they'll probably do is, the Washington term they use is kick the can down the road. That they've been doing it for 3 years, 4 years, they'll do it again. So we've got just about a minute and a half left. Any final comments, Bob?
Well,
Quickly.
I'm optimistic about the future. I think the new law is going to provide opportunities to improve quality, affordability, and access to health care. That's good.
You know, I'm very proud to be a member of the provider in this community. We have 2 outstanding hospitals. In spite of all the issues that we have, it's just not local, it's national. And I think with the new thought process that the country is going through, the care is going to be better. People will demand, and we have to show that we provide good quality care in a measurable way, not some things that is hard to define.
You personally enjoy a fabulous reputation, and your patients just sing your accolades, Doctor. You should know that. I know. Mariette, what about yourself?
I would agree with that last statement, and I'd say that, in Iowa, up and down, vertically and horizontally, we provide excellent medical care. But I would say that there's a lot of uncertainty. So no one knows what the accountable care organizations will do, how they'll integrate with community-based organizations, and what the future will hold. Will we still have the same level of excellent medical care, or will we have more community-based care that's wellness?
And on behalf of the Interreligious Council, thank you for joining us this Sunday morning, and go out and make our community a better place today.